Good afternoon, everyone. So I'm going to talk about expanded hemodialysis. It's somewhat newer technologies which are coming up in the dialysis. So membrane technology is continuously evolving and with the goal to mimic glomerular membrane. So what is the need to for this evolution? Is basically the inability to adequately remove large middle molecules more than 15 or more than 25 kilodaltons with conventional hemodialysis. That is the limitation of conventional hemodialysis, which is tried to be overcome by these newer technologies. So what are these middle molecules? Middle molecules are not merely waste products. They are pathological drivers, which includes pro-inflammatory molecules like TNF-alpha, then interleukin-6, then adipokines. They are immune-related molecules like complement factor D, etc. And they accumulate and they contribute to long-term complications like cardiovascular mortality, amyloidosis, and others. So where we are standing now, we have a technology of online hemodiafiltration, which is currently most advanced technology employed in routine clinical practice at some centers. It employs diffusion and convective clearance to improve spectrum of uremic toxin clearance. To have maximum benefits of online hemodiafiltration, we need to achieve high convective volumes, as it has been discussed in first talk of this session. Like 23 liters in every session we have to achieve a clinical benefit. And this high convective volume clearance is limited by having good vascular access flow, then having ultra pure water. We need special machine and special lines for this. So what is new in expanded hemodialysis? In expanded hemodialysis, the diffusion and convective transport is combined inside the dialyzer, and it allows higher clearance rate without need of any fluid exchange. So this doesn't employ substitution fluid, which is required for online hemodiafiltration. So these special membranes, they have high retention onset and medium cutoff membranes. And this type of dialysis which employ medium cutoff membranes, it's called as expanded hemodialysis. And this term was coined in 2017 by Dr. Ronco. So before going into details of that, we'll brush up the concepts of sieving coefficient and molecular weight retention onset and cutoffs. So sieving coefficient is basically concentration in the filtrate divided by concentration in the feed or inlet fluid. When sieving coefficient is 1, it means that that particular solute is completely removed from the inlet fluid. When it is 0.9, that means retention of that particular solute has started now. So retention it's onset of the retention. When it is 0.1, then we call it as a cutoff. Like after that, it will not be satisfactorily removed, and 0 is that it will be completely retained. So this particular graph shows on x-axis. On x-axis, you can see molecular weight of the substance, and on y-axis there is sieving coefficient. Yeah. So there are two lines here. One is the high flux membrane. This is the graph of high flux membrane, and red one is the graph of medium cutoff membrane. So we can see in the high flux membrane, the retention onset, that is 0.9 sieving coefficient, achieves somewhere around a molecular weight of 1200 to 1300. So this is the molecular weight retention onset for high flux membranes. But for medium cutoff membranes, this retention onset starts at more than 10,000 or about 12,000 daltons of molecular weight. So this means that medium cutoff membranes, they will completely remove large middle molecules up to weight of 12,000 or almost up to 15,000 daltons. And when you come to this side of the graph, the molecular weight cutoff, that is, they will stop removing any of or stop removing satisfactory amount of that particular solute. So that is for high flux membranes, it is somewhere around it will come around 25 or 28,000 daltons, but for medium cutoff membrane, it goes somewhere to 45,000 daltons. So what is the characteristic of these MCO membranes? They have large and more homogeneous pores and reduced pore site dispersion. They are highly selective with controlled porosity, allowing greater removal of larger molecules of 48 to 45 kilodaltons without significant albumin loss. There is increased internal filtration rate by reducing the internal diameter of the fibers and increased fiber length, which leads to increased convective volume inside the dialyzer. So these are the examples of medium cutoff membranes which are available in the world currently. So what we have in India currently is the Theranova dialyzer, Theranova 400 and Theranova 500. So what is the clinical evidence for the use of these particular membranes? So first is about the safety. So are these dialyzers safe? So it was studied by Wiener et al. In the randomized control trial. Primary endpoint to look at the albumin levels at 24 weeks. And they found that the albumin loss was not significant, or it is stabilized at the end of 24 weeks. And as other efficacy endpoints, the reduction ratio of the lambda light chain as 24 weeks was compared, and they found it was 33% more reduction ratio as compared to high flux membranes. In the secondary efficiency endpoints, there was also significantly large reduction ratios for other large mineral molecules like complement factor D, free kappa light chains, TNF alpha, beta 2 microglobulin at both 4 weeks and 24 weeks. So another study which was not randomized, it was conducted in Australia and New Zealand. It confirmed the sustained clearance of these toxins and showed significant reduction of both free light chains, kappa and lambda, as early as 2 weeks after starting HDX, that is expanded hemodialysis with Theranova. And when this membrane use was stopped, that after 24 weeks, then these levels again started rising. So this reinforces the membrane's therapeutic effect. So coming to meta-analysis of all studies have also confirmed there is superior clearance of larger medium molecules with the use of expanded hemodialysis as compared to high flux hemodialysis. So what is the effect on inflammatory markers? This particular topic or this particular area there is some improvement in removal of inflammatory markers, but there is some catch here. So one meta-analysis found that MCO dialyzers increased reduction ratio of TNF alpha by 7.7% and reduced the pre-dialysis TNF alpha in the serum levels as well. So with one session there was significant removal of TNF alpha, and even pre-dialysis TNF alpha levels were lower in patients who were undergoing expanded hemodialysis. But they found that there was no significant difference in interleukin 6 levels, no significant difference in the reduction ratio of interleukin 6 levels, although the overall serum levels of interleukin 6 was low. So this was attributed to the factors which are influenced beyond dialyzer membrane itself. That is, there is reduction in the mRNA expression for expression of inflammatory molecules like TNF alpha and interleukin 6. So there is potential anti-inflammatory effect at cellular level because of use of expanded hemodialysis. So coming to albumin loss, it has been found that in one meta-analysis, after excluding one outlier study which used earlier version of this particular Theranova dialyzer, there was no difference in significant albumin loss as compared to high flux hemodialysis groups. So in general consensus that while there is transient reduction may occur at the start of MCO therapy, over the period of time it gets stabilized. Coming to comparison between expanded hemodialysis and what we have currently is the online hemodiafiltration. So it is a complex comparison, and there are some disparities, and this largely depend on specifics of the sessions and specific of the goals which are achieved with each of these therapies. So for small molecules, both are highly efficient, there is no difference. But for large molecules, in one particular study done by Maduel et al., it was found that expanded hemodialysis was superior for larger toxins in high flux hemodialysis, but expanded hemodialysis was slightly inferior to optimum online hemodiafiltration, and with respect to large middle molecules. But other studies done by Recke et al., where online hemodiafiltration convective volumes was 23 plus minus 4 liter, expanded hemodialysis was found to be better for large molecules like myoglobulin and prolactin. So what is driving this difference is the convection factor. So high volume hemodiafiltration, which was employed by the Maduel study, they used volumes of about 30 plus minus 4 liters, and that gave slightly higher efficiency of online hemodiafiltration as compared to expanded hemodialysis. And this may not be practically possible with every session because of constraint of vascular access, and maybe we need to increase the time of that particular session. So reaching to this high convective clearance of 30 plus minus 4 may not be always possible. So if you compare both of them, the strength of expanded hemodialysis is when online hemodiafiltration is constrained because of various reasons like earlier mentioned. And there is ease of use of expanded hemodialysis, which requires less logistic complexity. So expanded hemodialysis is a simplified way to achieve near maximum large molecular clearance without technical demands of high volume HDF. Coming to safety profile, we have discussed about the albumin losses, that there is some albumin loss, but it is comparable to other modalities of high flux hemodialysis or even online hemodiafiltration, and over long term it gets stabilized. Coming to safety profile with respect to endotoxins and pyrogens, it is a theoretical thought that if there is more internal filtration, there is more chance of exchange of pyrogens and endotoxins. But there was a interesting study, in vitro study done by Shepard and et al., where they artificially increased the endotoxin levels and compared it with the how much it is getting transferred into the other side of the membrane by using polyvinyl fluid into the other side rather than blood. This was in vitro experiment, and they found there was no significant increase in the endotoxin levels in that particular experiment. So it was concluded that they are safe with respect to risk of transferring endotoxin across the membrane. But we have to guarantee that dialysate water which is employed follows the current regulatory guidelines. The allergic reactions, it has not been found to have any excessive allergic reactions as compared to routine or which are regularly can happen in any dialysis session. So concomitant medication clearance, there is no recommendation to switch the patients from high flux, when patients are being switched from high flux dialysis to expanded hemodialysis, to change any medications. Coming to clinical benefits, it has been found to have positive impact on vascular disease by reducing vascular calcifications. They reduce erythropoietin resistance index, improve nutrition. There is reduction in systemic inflammation by way of reducing TNF alpha levels and other cytokine levels. There is improved quality of life by as evident by reduced prevalence of restless leg syndrome, decreased self-reported pruritus outcomes, and improved post-dialysis recovery time. It also reduces mineralization of adipokines and reduces risk of calciphylaxis. The word of caution is that online hemodiafiltration, if you are using, we should not use MCO membranes. These membranes should not be applied to machine where online hemodiafiltration is done, because there is risk of significant loss of albumin up to 15 gram in each session. And isolated ultrafiltration should not be done with using MCO membranes. So if patient is on dialysis with MCO membranes, there should not be a programming of isolated ultrafiltration, because there is some loss of free hemoglobin, which is quite large molecular weight molecule, which is removed by expanded hemodialysis, and it will be read by the blood leak detector of the in the effluent circuit, and that leads to stoppage of the therapy. So isolated ultrafiltration should not be used. So in summary, expanded hemodialysis employs medium cutoff membranes. These membranes have high retention onset with more complete removal of large medial molecules. It has proven safety and superior clinical outcomes as compared to high flux hemodialysis, and it is an option where online hemodiafiltration is not optimum. It improves quality of life, nutrition, anemia, and metabolic bone disease, but staff and technicians using expanded hemodialysis should be specifically trained about this technology. Thank you.
It was a wonderful lecture. Just one or two questions, like whether this requires an ultra pure or just normal RO water will be sufficient.
Normal RO water can be.
So what
it is always better to have ultra pure water.
But what patient profile will we while selecting a patient for this expanded dialysis or median cutoff? So which type of patients are you going to select? Like sir said that HDF patient, if he doesn't achieve a 400 ml per minute blood flow, so those patients will not be a good. So those patients probably will benefit more with, I think, this type.
So those maintenance hemodialysis patients who are not candidate for online HDF, they will be this can be an option which can be done with minimal technical difference actually.
Its use in myeloma would be?
No, actually it has not been proven to be useful. Not lambda legends. So at present the Theranova 400 dialyzer costs somewhere around 3,500 rupees, which is some maybe 3-4 times more than regular dialyzer which we are using. That is the only cost difference, otherwise we can directly employ it.
Thank you, Sagar, for the talk. May I request Dr. Ambekar to hand over token of appreciation to Sunil sir. Sunil sir, please. With this, we have come to last session, which is on cases. I'll try to fit in 4 cases, but not take a lot of time from you.